because people have had trouble on the inside doing a much more complex ablation, most people just do a combination of the four corners, which is to me like half a wall of the first wall. And then if they bring the person back and they do something more advanced, they're going to do maybe the posterior wall and roof. Some people might go around the lateral wall, which is where a structure called the left atrial appendage is. And that's a little pouch-like structure coming off of that wall. And that is definitely a source of atrial fibrillation rhythm. And so people will go around that. And most of the time, that's the most advanced I've seen people who are doing more advanced ablations do. And a lot of people may not even do that. But after doing this for over 20 years, I have seen that the AFib can continue to progress in these more advanced stages of late persistent or long-standing persistent or close to permanent atrial fibrillation, where that's not enough, where areas on the anterior wall, the front wall, or the floor, or even spreading into the right atrium, the right upper chamber of the heart, is also present and needs to be done for you to have a chance of keeping this person from progressing into permanent atrial fibrillation. So that's where you get some more advanced techniques, such as the surgical techniques. Now, putting the old cut and sew maze, which is called the Cox-Maze procedure, that's the one that had the highest success rate. That's the one where surgeons stop your heart and do open heart surgery, crack your chest open. And then they used to, in the 1980s, make a incision with a scalpel and then sew it up and literally make lines or lesions to interrupt the electrical flow, which is kind of like what we're doing from the inside, except doing it mechanically instead of freezing or cauterizing or using pulses of electricity. And if you look at the lesion set of the old cut and sew maze, what we now call the Cox-Maze procedure, it was very extensive. That's why it had such a great success rate, because it made lesions. It did do the four corners of that back wall, which is AFib, where AFib always starts. So they would cut and make a circle around those four veins. And then they would also make a line across the roof, so interrupt signals from the roof, and then make a line across the back wall to sort of box out that back wall with lines of scar, so that any AFib signals in the back wall couldn't get out to the rest of the chamber, so got rid of that. And then they also made lines across the front anterior wall, across the septum, and also near the floor. So they really made lesions on all six walls. And they also made some lesions in the right upper chamber, which is where you see AFib sources developing in these almost permanent cases. So once it fills up the six walls of the left atrium, it will spread to some of the walls of the right atrium, and that's when the person's permanent or virtually permanent. So they made lesion sets in the right atrium as well, on the floor and around the appendage, because it also has a pouch-like appendage structure on its lateral wall. And in the original Cox-Maze procedure, they would also do the lateral wall of the left side, which is where that appendage structure, the left atrial appendage, is located. So they did a very, very complex lesion set. And so that's why they had such great success rates. So if you look at what they did, it wasn't just because it was surgical, it was also because they did a very advanced lesion set. Now, the problem with that is that that involved open heart surgery, where your heart is literally stopped and your breastbone is cracked open, and that takes a long time to recover from, and it's just major, major surgery. But it will probably get you a good result, irregardless of what stage of atrial fibrillation you're at. Because if you're at an early stage and they do that much complex lesion set, well, they're certainly going to get the back wall or the corners of the back wall, which is all you needed, and they'll do a bunch more. But eventually, if it spreads to that area, it will handle it. If you're at a much later stage, where your first fire is spreading to 4, 5, 6 walls, then it's going to have a good result with that as well. So they just did it anatomically. They just did the lesion set and they got great results. But it was such an involved procedure that surgeons have tried to do something similar to that, but being less invasive, where you don't have to have your breastbone completely cracked open and you don't have to have your heart stopped during major surgery. So that's where you have surgical procedures like the surgical hybrid ablation procedure, or the Wolf mini maze procedure. So let's look at what they actually do. So the surgical hybrid ablation is where they make a hole underneath your breastbone and they put up a catheter to the outside of your heart. And with that, they can actually get rid of AFib cells or make a lesion on the roof of the left upper chamber of your heart, the left atrium, and also all over the back wall and approaching some of the floor. So that is going to get rid of 1, 2, 2.5, 2 to 3 walls of the chamber. Now, interestingly enough, they can't reach with just that one hole. They cannot reach and get rid of all the AFib cells around the 4 corners of the back wall where the veins or pulmonary veins, I said, insert. And as we know, that's where AFib always starts. And so actually that's why they need to combine their procedure with an electrophysiologist or electrical cardiologist to go in on the inside at a later date or later that day to actually do from the inside, cauterize or freeze, whichever energy source you want, to finish up. And so at the end, they will have gotten those 4 corners, the pulmonary veins, which is the cornerstone of all of our ablations for AFib, and then also the roof, the posterior wall, and a little bit of the floor. So that is a much more involved lesion set. And so it's going to get a higher success rate with these more advanced cases of persistent or long-standing persistent atrial fibrillation cases. So instead of the 40% success rate in a persistent atrial fibrillation stage by just doing the 4 corners, by adding the roof, posterior wall, and a little bit of the floor, they can up their success rate to probably 60% success rate. It's definitely an improvement. Then there is the Wolf mini maze procedure. This is also a procedure that's done on the outside of your heart surgically, but doesn't involve cracking your chest bone, doing open heart surgery, or having your heart stopped like the Cox-Maze procedure. In truth, the Cox-Maze procedure, while very impressive, is very involved, takes a long time to recuperate from, and is only done in a handful of centers in the United States or even the world. It's just not that commonly done. When a surgeon says, I'm doing a maze procedure on you during your bypass or valve replacement surgery, they're really just doing the 4 corners, the pulmonary veins, the 4 corners of that back wall, because it's so easy for them. They just use a little device to freeze or cauterize the 4 corners, and it's not really any different than any cardiac electrophysiologist, even one not very experienced, doing that from the inside, which we already said is pretty easy to do. And there's many energy sources you can use to do it. So that's all they're doing. That's why just doing a regular maze procedure, not a full Cox-Maze procedure, which most surgeons don't do that, doesn't really have great results, because that's saying, hey, you're needing your bypass, you're needing your valve surgery. The surgeon's not going to, as an electrical cardiologist, he's not an electrical cardiologist, he's not going to say, well, what stage are you in? Are you paroxysmal, persistent, long-standing persistent? Well, I'm going to do more if you have persistent or long-standing persistent AFib stage, and I'm just going to do the 4 corners, pulmonary veins of that back wall if you're paroxysmal. No, they just do what they can do because it's super easy and they bill for it. And that's just those 4 corners, which means if you are at an early stage, they're going to get you a great result. But anyone could have done that from the inside as well, irregardless of energy source. But if you're at a later stage, once again, you run into the trouble where they're not going to get you the result, likely because it's just not enough. So to try to do more, you have the hybrid surgical approach, and that definitely does more. And then you've got the Wolf mini maze. The Wolf mini maze procedure, which is a standalone procedure, not done concomitantly with other surgeries because it's not cracking your chest bones, less invasive. It does the 4 corners of the pulmonary veins. So unlike the surgical hybrid ablation procedure, which requires a separate procedure from a cardiac electrophysiologist to complete that portion of the procedure to get you those 3 walls worth of lesions, they can make several holes from the outside of your heart to do the 4 corners or pulmonary veins. And then also they can electrically isolate or get rid of cells from the lateral wall, which is where that appendage structure, the left atrial appendage, is. In fact, they clip that structure, which not only reduces your risk for clots and strokes, because 90% of clots that form in atrial fibrillation does form in that structure. That's why the Watchman procedure, or procedures that we have to close up that structure from the inside, is sometimes done to try to get people off of blood thinners if they can't tolerate being on a blood thinner. Well, you can do that surgically as well. And so part of their procedure, they do that. And then they also do the pulmonary veins, or the 4 corners. Now, clipping the left atrial appendage does help your AFib, because after they clip it and it just scars up, a lot of the sources of AFib that are coming from around that appendage structure do go away. So it is like doing two walls. It's sort of doing part of the back wall and then the lateral wall where that appendage structure is. So it's kind of like doing two walls. And it definitely is more than just doing the back walls. And they will also say it's going to reduce your risk for clots and strokes. The downside I see of that procedure is when you look at what is being done, it's still not that much. I mean, you are isolating the four corners, the pulmonary veins. You are getting rid of sources or AFib cells from that appendage structure, which is the lateral wall of that chamber. And that's definitely an improvement. And you are also helping to reduce that person's risk of clots and strokes. But the downsides I see of it is some of us who do very complex ablations, well, I could isolate the pulmonary veins, whether I use cauterization catheter or freeze it or use pulse field ablation. I can do that in 45 minutes. And if I use a cauterization catheter at the same time, I could also mostly get rid of the signals around that or coming from that appendage structure. And that only takes an extra 20, 30 minutes and could be done in under 2 hours. And that's not major surgery onto the outside of your heart. You could go home either later that day or by the next morning and probably get an equivalent result. And then as well, if you have more cells, more sources on more walls, I could do that. Some of us can do that more too, even in the same sitting. So that's the difference between doing it anatomically versus doing it functionally, where you're actually trying to get rid of the cells based on what you see. So it's definitely doing more, but I think what it's doing is still fairly limited. Now, the argument for surgical procedures will be that, well, they make better lesions, they make deeper burns, and that gets rid of more cells. And there is truth to that. I would say that 10, 15 years ago, one of the major limitations for those of us who are doing advanced ablations and trying to get better results than just the four corners of the back wall was that our catheters couldn't make very deep burns or lesions. And so you get people with thicker heart walls and you're just not getting rid of the cells. So if you do it surgically, you can definitely make better lesions. You can burn more completely. You can definitely get deeper amounts. Whereas from the inside, we can crank up the power to try to make a deeper burn, but then you worry about risk of complications like making holes in the walls of the heart with dangerous bleeding. And so that's why we have to be careful. Whereas from the outside, they already have your heart possibly open or making holes to it, so they could deal with that complication. There's less chance of it. If they did have it, they can deal with it right then and there. So they do have that advantage of making more complete lesions. However, I feel like that advantage has been mitigated quite a bit in the last few years because now we actually have what we call force sensing catheters, where we can see the force we're putting on the heart walls with the catheter, the ablation catheter, and we can see that we're not putting too much force and that we're putting appropriate force. And then that will allow some of us with experience to crank up the power to higher power settings like 50 watts, and then be very, very careful using our experience of doing thousands of cases to make better lesions. And so that can help make more deeper lesions and bridge the gap between what we can do from the inside versus what somebody can do from the outside. Now, if you can do that, then I think that you will probably have the advantage of doing it from the inside. Now, if you're somewhere where somebody isn't going to be able to do that, if you're in an area where the cardiac electrophysiologists that are doing the procedure only do basically the back wall or the corners of the back wall, kind of a basic, what everybody else does, and you need more because you're at a more advanced stage, then I would say go for the surgical hybrid procedure where they can get rid of the stuff on the back wall or the roof, or go for the Wolf mini maze where they're going to be able to do that, and also around the lateral wall where that appendage structure is. You're going to get probably a better chance of result. But if you go to somebody who's able to do more from the inside more effectively, then you could get the same result and have less recuperation and be a lot easier and a lot easier recuperation and recovery time. Now, they will also say with the Wolf mini maze that, well, they're also clipping that appendage structure. So that's almost like doing a Watchman from the inside during that same procedure, which gets you off the blood thinner. Well, yes and no. Can it get you off the blood thinner? Yes. But remember, the studies that show blood clots form in atrial fibrillation in that left upper chamber of the heart overwhelmingly show that blood thinners protect you the best. That if you're on a blood thinner taken properly, thinning your blood properly, that your risk for clots and strokes is going to be reduced to less than 1%. Whereas with a closure of the left atrial appendage structure, whether you do it from the outside with a clip surgically, or you do it from the inside with a Watchman type device, that will definitely reduce your risk significantly. And there are certainly some recent studies that have suggested that the protection from clots and strokes may be comparable to a blood thinner. The data and research still overwhelmingly backs using a blood thinner to reduce your risk the best. And I think more studies are ongoing or needed to really prove that closing up that appendage structure is really all you need. Because I personally have seen clots form outside of that appendage structure. For example, recently I had a patient where I was bringing them for an atrial fibrillation ablation. They were on a blood thinner and maybe not taking it as reliably as they should. And when we started to do the procedure and we looked at their heart under ultrasound, we saw a clot formed in the chamber of the heart, just flipping around. And it was not in the left atrial appendage. It was actually anchored at the septal wall, just flipping around. And so, of course, we didn't do the procedure. I put him back on his blood thinner, stressed that he take it religiously every single day. And after a month, we did another ultrasound and we saw that it had resolved. Now, if that person had just had a Watchman or a left atrial appendage clip, they still would have had that clot. They probably would have had a significant or severe stroke. So we definitely know that 90 to 92% of clots in atrial fibrillation form in that appendage structure, but there is the ability to form it outside of that structure. And I've personally seen it, and I'm sure other electrophysiologists have seen this as well. So while I wait more data to say whether it's safe to just put in a Watchman or clip the left atrial appendage and then say, that's it, you don't need anything more, personally, I feel like at this point in time, in 2024, the data still would suggest maximal protection with a blood thinner. And so therefore, I'm a little bit hesitant about just closing up that structure and saying you don't need to be on a blood thinner and you're protected just as well, especially when we can do the results of the Wolf mini maze from the inside. It would take me under 2 hours and it won't be major surgery. And yes, if you're going to be on your blood thinner, because that provides maximal protection compared with just, in my opinion, maximal protection compared with just closing the appendage, then you're actually, in my opinion, having a similar or better result with less recuperation, and you're better protected by staying on the blood thinner. So just different pros and cons. Now, it's true that if you cannot make good lesions from the inside, if you don't have the skill to make good additional advanced lesions on the other walls besides that first wall, then you're better off not doing it from the inside, and surgically it might be a better option for you. Because the problem here is that people try to do more advanced ablations, and they make little burns to try to make a roof line or a floor line, and they're just not very good at it because it takes a lot of hand skill to cauterize for 30 seconds a minute, dot by dot, and make complete lines. And here's the problem. If you don't make good lesions or lines, if you're going to do a more advanced ablation for somebody who needs it, then you could actually cause more problems. You could certainly, because people will say, well, if there's stuff on the roof and there's stuff on the lateral wall and stuff on the septum and stuff on the floor, just blast some cauterization on the roof and blast some on the septum and blast some on the floor. And sometimes these people won't have very much AFib. You really get the sources. But if you're just making scatters of scar, electricity is like water. And even if you get the source that's firing off, if you create a lot of patchy scar, then you can actually create an intermediate abnormal rhythm called an atypical atrial flutter. And this is where electricity creates a circular circuit within the scar. And then you come back and your heart rate's racing, and it's not technically AFib, it's an intermediate rhythm or a related rhythm called an atypical atrial flutter that's basically partly created by the patchy scar that you made. You got rid of one rhythm and then you sort of created another rhythm. And so that's why some people will say, well, I don't believe in these more advanced ablations, because if you do them, then it just creates all this patchy scar, and then all these people have these atypical atrial flutters. Yes, nobody said doing an advanced ablation is easy. That's why if you do it surgically, you can make more complete lines and complete lesions, but that's a much more involved procedure. Some of us have developed the skills to do that from the inside and use higher power wattages settings with higher force and carefully to make more complete lines, and can minimize the likelihood of these intermediate atypical atrial flutter lesions. So it's once again a skill set, but if you say, well, I don't want to learn how to do that because if I try to learn how to do that, it's not easy and it could take a few years. In the meantime, I'll have all these people where I got rid of their AFib, but then they're in this intermediate atypical atrial flutter rhythm. Why would I do that? Just keep doing what I'm doing. Yes, but what they're doing isn't getting a lot of people the result, because a lot of people are at the later stages, persistent, long-standing, persistent, almost permanent, and they're not getting them the result. But then again, unfortunately, in my opinion, you actually get paid more to do it that way because we don't get paid for results. We actually use codes and we just build the same codes. So if I, for example, somebody who does more advanced ablation blocks out 4 hours and I go in and you have 5 walls worth and I get rid of the 5 walls and you don't have any more, well, then I can only do 2 procedures a day. Whereas if somebody's saying, I'm just going to do that first wall because it's easy and whether it gets rid of it all or not, we'll just do it. They may be able to put on 4 cases a day because they're only spending an hour and a half with each case to do a little bit. And then they may bring you back 3 or 4 times, even if they do a little bit on the other walls, wall by wall. They may break that out into 3 or 4 procedures, where some of us may be able to do that in 1 procedure, but they're going to make 4 to 8 times the money because they're putting on twice as many cases the same day and they're getting the 2nd and the 3rd and the 4th. I rarely do a 3rd procedure. I usually get rid of the bulk of it with the 1st procedure, and I only do a 2nd procedure maybe 20% of the time. So it just depends on your technique and what you're doing. But I personally believe that if somebody can get rid of more and the skill to do it, that they should try to do it. If you don't have the skill to do it, then fine. But unfortunately, sometimes when people don't do very much, just because of the thing of, well, that's what they do, and they feel like if they can't do it, nobody can do it. They think they're the best, whatever. But there are other options out there. There are more that can be done.